Now that we have gone over a little bit more of the neurosystem, we're going to go back and talk about some of the lesser recognizable syndromes such as myasthenia gravis and Guillain-Barré. So I know you've covered both of these in previous courses, but I want to make sure we touch on some of the finer points of these, the testing, the medications, those type of things. So we're going to start with myasthenia gravis. MG is how it's listed in the study guide because it's a lot to type out repeatedly. So this is a chronic autoimmune disorder that also has some neuromuscular findings. So what we most often think of is fatigue and severe muscle weakness. So this is sort of an ebb and flow. You have periods of remission, and then you have periods where things are getting a little worse. So this is actually caused by the thymus gland. So usually this gland is inactive after puberty, but in the case of myasthenia gravis, it continues to make antibodies, and that's what causes this muscle disconnect. So the what we normally will think of along with the severe weakness is the eye muscles. So patients usually talk about double vision, diplopia, and it could be one eye, it could be unilateral, it could be both eyes, and ptosis, which is a drooping of the eyelid. Also, you'll have some facial weakness, some muscles in the jaw, muscles in the throat. So they do often have trouble speaking. They have trouble swallowing. Maybe their voice has periods of time where it's weak. And if those neck muscles are really affected, the head will tend to jut forward just because it takes so much energy to hold the head up. So when we talk about periods of exacerbation and remission, depending on stress and any infections or fever, if you're overexerting yourself, extreme heat or cold, all of these can have effects on the manifestations and make them more pronounced. Now, just when we talked about thyroid, we talked about thyroid, hypothyroidism, and then we talked about the life-threatening condition. So, myasthenia crisis is a sudden exacerbation of weakness. And with that, because it is so sudden, we have a risk of respiratory compromise. So, because the muscles are so weak so suddenly, we have trouble with the airway and we have trouble with respiratory. So, a lot of times this is caused by if you're not compliant with your medication or if you haven't been starting on your medication yet, if this is the first time that you've been diagnosed. So, we want to prevent respiratory failure and any aspiration risk. We're going to see some tachycardia, tachypnea, respiratory distress, and then what we had before, but on a more severe scale of the dysphagia and the impaired speech. Okay, so I'm going to move this to the other side here so you can see. So, this is the flip side. So that was myasthenia crisis. This is the cholinergic crisis. And so where the other one comes from lack of medication, or not starting on the medication yet, the cholinergic crisis actually is a result from overdoing the medication. So the class that we use is the anticholinesterase. That's the class that treats myasthenia gravis. So if you have too much of it, you will have similar symptoms with severe muscle weakness. You're going to have severe respiratory distress, also some vertigo, maybe, and some GI symptoms. But here's the thing that's kind of interesting. They both are life-threatening and they both appear very similar. And so it's very difficult to differentiate between the two. So a lot of history and assessment needs to go into that. Did you take too much? Did you not take enough? And trying to balance the both. Priority is always airway. It's always supporting a respiratory effort and ventilation. But we do know that they do have some minute, distinct differences, but it's very difficult to tell the difference. So if you have an initial diagnosis of myasthenia gravis, what you're going to use is something called the Tessalon test, right? So the generic name is hydrophonium chloride, but we're going to call it Tessalon. So what they do is the medication that typically makes this better that we're going to take is that anticholinesterase medication. So they will actually inject you with this medication and they'll wait and see. And so usually there will be some significant improvement in the ability of your muscle strength, and it lasts for about 5 minutes or so. And that confirms that, yes, you do have it. Okay. And if you are in the middle of a myasthenic crisis or a cholinergic crisis, it will work for both of them. So both of them, you will have a temporary reversal of that muscle weakness. And that's how we tell that, yes, this is an immune neuromuscular disorder instead of other things. Okay. But here's the little asterisk. If you are using Tessalon for the test, and it is a cholinergic crisis, that medication makes you at higher risk of getting into the dysrhythmia VFib. So, because we can't really tell if it's one or the other, we are going to make sure that we have a crash cart ready and we're going to have atropine available because it's, again, if this is a cholinergic crisis, we're going to need to have the reversal, which is atropine. Okay, so just keep that in the back of your mind if you ever are doing a Tessalon test. Medications that we use for this, again, the anticholinesterases. The most common ones that we're going to use are the acetylcholinesterase inhibitors, okay? And the words are right there. I'm going to do my best to pronounce them. It's pyridostigmine and neostigmine, okay? So you're probably going to recognize those on what they look like, right? Not on my ability to pronounce them. And additionally, if those are not cutting it because it is an immune disorder, we can go ahead and treat with immunosuppressive medications like glucocorticoids as well. So prednisone, things like that. So balancing both the muscle, the neuromuscular end of it, and the immune end of it. Now, if you don't know where your thymus gland is, it is actually located in your chest. It's between the lungs and sort of behind the sternum. So the best way, the most conclusive way to get rid of this disorder and to go ahead and get it corrected is to remove the thymus gland. And that's what's recommended if you're under 60 to go ahead and get that removed. Now, there's two different ways that can go about that. One that can go in through the neck and go down. It's less invasive, but because of the location of the gland, they can't get as much of it. The other option is to go transsternal. So think of everything we talked about open heart surgery, and that's the same thing. That way you can go ahead and get almost all the gland without having to, wonder if you're going to have the symptoms return. But it is more invasive, and we do have to go through all the things with open heart surgery, with the chest tubes and the chest being wired shut, and then center spirometry to encourage inflation, all the things, right? So just understand that's where the thymus gland is, and that's how you go about reversing it. Now, one of the other ways that they can do things is plasmapheresis. And so we're going to talk about this on multiple things today. So, plasmapheresis is an exchange of plasma. Okay. So, this is sort of similar to a dialysis machine in which they spin the blood and remove antibodies. And they separate the plasma from the other blood components. And then that plasma is removed and it's replaced with donor plasma. Okay. So I'm going to show you a video on this to kind of give you an idea of what it looks like. This is a patient story. And just to give you some frame of reference as to what we're talking about.
Was so sick that she didn't feel good enough to play with either one of us, and she always needed to be alone. She didn't really want to interact with anyone when she was so sick.
Usually, antibodies protect people from disease. But in Emma's case, she has some antibodies which have gone rogue and are attacking her own body.
There are fewer than 100 cases in the world reported of this condition, and even fewer in children.
I'm Emma Hendrickson. I'm 15 years old, and I'm from Guilford, Connecticut.
I first met Emma in my neuroimmunology clinic. She came to me with a constellation of symptoms. She had this burning pain in her leg. Her leg would get very swollen. It would make it very difficult for her to walk.
Good morning, Emma. Good morning, Dr. Although blood looks just like a red liquid, it's in fact made of different components, which include the red blood cells that make blood red, the white blood cells, which are the immune system, the platelets, which stop bleeding, and plasma, which is a clear yellowish fluid which contains antibodies. They make sure that infections aren't allowed to spread very far in our bodies. Apheresis literally means to carry away. When we perform apheresis procedures, we are removing a component of blood from patients who have a disease. in order to improve their symptoms.
These are the ports that are in my chest and run to my heart. You have to have 2 IVs for each treatment, and your veins get weak. So having needles in your chest is not fun at all.
The preparation of the vascular access takes about 30 to 45 minutes. And after that, she will be connected to the automated apheresis instrument.
This is me for the next hour.
When we connect this machine to Emma, it will bring a small portion of her blood into its inner chamber, which contains a spinning bowl, which is able to separate her blood into its components. The plasma that's collected during the procedure is replaced with albumin, which is a blood protein that is manufactured from plasma from healthy blood donors. And once her procedure is complete, she receives an infusion of a medicine called IVIG, which lasts an hour or two.
So this is obviously a pediatric patient, but it was the best video that I could find that actually showed what the process looked like. So it's similar in theory to a dialysis machine, which is things are taken out and they're processed and then returned to the body. In this case, it's the plasma is not returned to the body. It's replaced with donor plasma. So just to give you a little, if you ever hear plasmapheresis, apheresis, plasma exchange, that's what we're talking about. So nursing interventions for this condition. So we want to do our best to prevent it getting to the point where it's an emergent situation, the myasthenia crisis or the cholinergic crisis. Because it has to do so much with a weakness, especially in the face and the neck, we're going to be making sure that we are encouraging them to clear their airway, to cough, to deep breathe. And then also when they're eating, it's going to be affected. So making sure we're pausing, taking a swallow, making sure we're clearing our mouth, small bites, making the calories count. If they're able to only eat a certain amount of time, we're going to make sure we need to use nutrient-dense foods. And we're also going to really focus on clustering our care and teaching them to cluster their care as well to allow plenty of time for rest periods and energy. Because this is a neuromuscular condition, they get fatigued very easily. We want to make sure they avoid extreme temperatures, hot and cold, because those are known triggers for our immune system. Also, quinine, which used to be a medication we used a whole lot. Now we find it in tonic water. If you're a beverage connoisseur, you may have seen some drinks with some tonic, like gin and tonic. But it is oftentimes recommended for muscle cramps and things like that. In patients that have myasthenia gravis, this will actually make their muscles weaker. So we want to make sure if for some reason this is something that you consume or this is a home remedy that you use, that you know to abstain from that. What we want to teach them is to be compliant with our medication regimen, just like everything else that we have that's autoimmune. It's very important that you take the medication the same time every day. You don't skip a dose. We want to make sure they understand what the symptoms are. If they are getting worse, if they are noticing some changes, that they let us know before they get to crisis levels. Anything that we can do to avoid stress, to make sure that we are getting plenty of rest, making sure we're doing support groups and setting realistic goals. You're probably not going to be climbing Mount Kilimanjaro with this. However, there's no reason why we can't work on hiking, right? So making sure our goals are realistic. And then if the person is of childbearing age, they need to understand that the medications that we use for this condition do cross the placental barrier. So if that is something that's important to them, then we need to make sure that we're having some discussions as far as what our planning is going to be. Okay, the next one we're going to talk about is Guillain-Barré syndrome. This is rare, just like myasthenia gravis is rare, but this is an acute autoimmune disease. So this sort of falls in the same bubble, I guess you could say, as multiple sclerosis, meaning that it is a demyelinating disorder. So that's the coating of the nerve, of the neuron. And this hallmark of Guillain-Barré is this ascending paralysis, right? It moves up. The difference between this and MS is that it's not permanent. It doesn't typically cause permanent paralysis, but it is a very long process to get it back. So typically it's flaccid paralysis, meaning very floppy, loose a muscle that is not able to move. And then if it ascends high enough, it actually does make the diaphragm flaccid. So they will have to be on a ventilator. So this is often a medical emergency based on the fact that they are unable to breathe on their own unassisted. So our patho for this is poor nerve impulse conduction. That's what the demyelination is. And it causes sudden onset of muscle weakness and loss of reflexes. So because this is a immune disorder, if you look in your book, table 44.1, it actually describes the three stages of this, where it's progressive, where it stabilizes, where you sort of plateau with your symptoms, and then where you head to recovery. But just knowing that this can take up to 2 years. So read that table and sort of look at what that's going to be. I don't have time to put it all in the PowerPoint, but I trust that you can look in your book. So when you're looking to diagnose Guillain-Barré, you have to rule out other things as well because it is sort of a vague type of presentation. So we're gonna rule out things like Lyme disease, metal poisonings, obviously anything neuro, right? Anything like stroke or hemorrhage or AVM rupture, things like that. Even the flu, we want to make sure we rule out. So this is going to be based on our symptoms. And again, those decreased reflexes are going to be a really good indicator that something's going on, in addition to that weakness. We can do a lumbar puncture and look for elevated protein in the cerebral spinal fluid. And we can use electromyography, which is an EMG, and that's where they put the needle into different parts of the body and they test the nerve conduction. It's uncomfortable, but that is one way that we can kind of diagnose. So there's not a hard, fast test necessarily, but if we see positive testing, we can kind of put the pieces together and figure out what it is. I'm not big on mnemonics, but this one sort of made sense. So GBS is paid. So this is the list of things you look for, which is that growing weakness, which is the ascending paralysis, right? Breathing problems, sensory disturbances, protein in the CSF, that neuropathy, autonomic neuropathy, because there is pain associated with this, any type of infection, and then the nerve studies, the EMG that we just discussed. So if this is something that helps you, go ahead and use it. For this, we are going to use IVIG, which is IV immunoglobulin, and that's going to help suppress those antibodies that are attacking the myelin sheath causing this disorder, right? And the other thing is to consider this is a very painful disease, is a very painful syndrome that we're going to have for the next few years. Lots of neuralgia, lots of pain, and so we have to stay on top of that. Additionally, if we're not able to move, right, ascending, so we know it starts lower, we're not going to be moving very much on our own, right? So maybe some passive range of motion, but not active. So anticoagulation to prevent clots. And then because our muscles are not responding to those impulses, we don't have good tone. And we know sometimes when we have that, we have a lot of peripheral vasodilation, which causes our blood pressure to drop. So sometimes we need to have a midodrine or something that's going to elevate our blood pressure. We want to make sure, especially because they are going to be immobile for so long, that we are supporting their nutrition. So, because again, this is autoimmune, they are in a hypermetabolic state. So, we want to make sure they're having adequate calorie intake and electrolyte fluid balance, keeping the muscle that we have and preventing further muscle wasting. So, because of that, and depending on where the paralysis is, TPN may be something we need to require to make sure that they get the support that they need. Again, we can look at plasmapheresis. Same thing. We're going to do the removal of the antibodies that is in the plasma. But with this, we're going to try to use it as early as we can in the syndrome. And we can also infuse an immunosuppressant at the same time. So typically, this is done very frequently in the first week or so of the syndrome. So 8 to 10 days, we're looking at 3 or 4 exchanges to really try to aggressively remove those antibodies and minimize the amount of paralysis and damage that we're going to have. Because it's such a long load to recover, a long road, we're going to have an interdisciplinary approach. We're going to have to involve physical therapy, occupational therapy, and it's very hard because this is so long, right? It's not I rolled my ankle, I had surgery, I need to just rehab and recover. This is years that it will take. So we try to introduce this therapy as soon as possible, understanding that it's going to be long term. It's good. What's going to be crucial to our full recovery. And because we have such severe muscle atrophy and loss potentially with the paralysis, they may have to relearn quite a few things. They may have to learn to feed themselves, to walk, to tie their shoes, whatever it is they need to do. Also, remembering this is very painful, right? Lots and lots of pain. So, we need to make sure if we are encouraging them to do their physical therapy, occupational therapy, we're doing adequate pain control to make sure that we're pre medicating so that they're feeling good enough to do their therapies. So, our interventions, our number one is going to be our airway, right? A, B, C's, D, E, F, airways at the top. Again, if that paralysis ascends to the diaphragm, we have some major problems. So, we need to make sure that is where our focus is. But we also want to make sure we are promoting adequate air exchange. We are turning, we are trying to deep breathe, we're suctioning to keep everything open, right? Making sure that they have good skin integrity as we're turning, as we're doing different things. If they're unable to feel or move, we know that we have a risk of skin breakdown. And this is very similar to ALS, in which there is not a cognitive factor. So many times they are awake and alert, but they are unable to move. So we understand that communication is important, that we have to make sure, just like we talked about with trach, we want to make sure there's a way to communicate, whether it's blinking, whether it is, taking a deep breath, whatever the case may be. When we're monitoring pain, there's a term that's called the stocking glove pattern, and that basically means it starts with our hands and feet and our legs and then goes inward. So a lot of the pain is going to be in those peripheral. So we want to make sure we are encouraging pain relief, but also our non-pharmacologic. If this is going to be 2 years or so of recovery, we really don't want them to be dependent on opioids or narcotics or whatever they're taking by the time we're done. Another thing to consider is if you are going to be administering pain medication and they do have ascending paralysis, we are at risk for respiratory depression anyway. Careful respiratory assessment. So, what do we tell our clients? Well, this is super rare, but it can be triggered by vaccines. That's why when we administer our flu vaccines, one of the boxes that we check is, have you ever had Guillain-Barré, right? So if you've had it before, we're going to stay off of vaccines, especially things that flu vaccines or things that are going to be more live vaccine or live attenuating. We need to keep reinforcing that this paralysis doesn't have to be permanent, right? It's temporary, but that's really difficult when you are looking at years of rehab to get you back where you were before. Okay. They need to understand when we talk about that orthostatic hypotension, we know what that means, but the family and the client might not know what that means as they work to stand up and they start to feel dizzy. We don't want them to have a risk of falls. And we want to make sure we're taking care of everybody involved, whether it's the family, whether it's the client, getting them connected with support so that they're in a good state of mind to proceed. So this is a video of a gentleman who had Guillain-Barré. So I would like to share that with you so that you can have an idea of what it looks like. So this is an older gentleman who ended up with this very sudden onset.
I was on a business trip in visiting Kansas City, and I noticed on my way back from dinner, my left foot was flapping. I couldn't quite control it. I went to bed, and I had a lot of pain in my back that night. The next day, I went to the meeting and flew home, and I got progressively worse, and I had no idea what it was. The next day, I went to the doctor, my GP, who thought it, because of other issues I had that his first thought that I had some kind of spinal cancer. So he suggested I go immediately to the emergency room.
That first night in the emergency room, it got so that you really needed my help to walk at all.
Yeah.
And things just started to progress, spiral downward.
I couldn't move. I had very little feeling anywhere below my neck.
Then he couldn't close his eyes. And for 4 days, he didn't close his eyes.
I remember being moved to the ICU. I remember my first hour in the ICU, and I remember nothing more about the 9 weeks in the ICU. Nothing.
So finally, it was decided that he had GBS.
GBS, or the Guillain-Barré syndrome, is a progressive paralysis that affects patients of any age, resulting in weakness in the arms and legs with loss of sensation. And in a significant number of patients is considered a neurologic emergency because patients may not be able to swallow or actually breathe on their own.
It was like being in a black hole. It's like he fell into a black hole, and there was no path of certainty for anything that was happening to him or if that he would get well. And so a woman from Doylestown came and visited us in the hospital through the GBS Foundation. And I couldn't wait to see her. You know, it was just so wonderful to have someone out in the world that had this 1 in a million kind of disease.
And then the letters started to come.
Yeah.
Notes.
Then we started to get notes. And by then, Chip
from people that had Guillain-Barré.
Right. And that was just so wonderful to read. 10 years ago, I was in the ICU for 9 weeks, and that just helped me so much realize that that there was hope and that we can hold the fort.
So then I started to make progress.
Right.
Slowly.
Yeah.
Got rid of the Hoyer lift, got rid of the wheelchair, got rid of the walker, got rid of the cane.
got rid of the hospital bed. Like each
that was
thing
wonderful.
We rolled out of, we celebrated.
I came home in mid-March of 2012, so it's a little over 2 years that I've been home. Qualitatively, I have absolute quality of life. Functionally, I can do most everything that I did before. I can play golf. I can
ride bikes.
I can be your laborer in the garden.
Right. Can weeds.
Ride bikes. Yeah. I mean, there've been hundreds and hundreds of thousands of people that have had GBS, but it's amazing how many physicians never heard of it, couldn't begin to diagnose it. And people go for weeks and weeks and they're just devastated. And the foundation offers a resource for them to gain the knowledge they need to cope with their condition.
So because this condition is relatively rare, he is right. There are a lot of people who do not necessarily lead with that, knowing that that isn't even a differential diagnosis. So if you are assessing your patients and if you are going through, this really seems like something that I should be kind of thinking about. This really seems like something that I remember hearing about in nursing school. Make sure that you are advocating for your patients and make sure you're not afraid to say, I remember hearing something about this when I was in nursing school. All right, we're going to do some practice questions just to kind of tie this up and get some extra practice. So the first question, a 47-year-old getting up in the morning and performing their ADLs. So they were diagnosed with myasthenia gravis 6 years ago. What would we find most likely due to this diagnosis? So what is the client going to struggle with? Listening to the radio, sitting in a chair, controlling bowel movements, or eating breakfast? And the answer is sitting in a chair should be. Yes, sitting in a chair is what the answer should be. Let me see 1 second. So, excuse me, the answer is making sure they are able to eat breakfast. So using those peripheral muscles, the weakness would be more pronounced, trying to do more of the fine motor type things. So eating breakfast is going to be what we would associate with myasthenia gravis. Okay, education on testing for myasthenia gravis. Which statement indicates understanding of the procedure? So the EMG will show an enlarged thymus gland. The spinal tap will show high levels of protein. If I get better after the Tessalon test, then I will know that I have it. Or if I have it, the MRI will show plaque and tissue breakdown. And the answer for that is yes, the Tessalon test is what we use to confirm. So giving the acetylcholinesterase is going to make the muscle stronger. That's going to confirm it. Now remember, what's our antidote to the Tessalon? And that's atropine. And we're going to use that if when we have a cholinergic crisis, it starts to throw them into a dysrhythmia. Okay. And then remember that the lumbar puncture we don't use for myasthenia gravis. That is what we use for Guillain-Barré, and patients may tend to have more protein in the CSF. So that would be our indicator for that. All right, so caring for a 32-year-old female with MG, what medication would they anticipate administering? Right, you don't have to pronounce these, you just have to look at them. And the answer is D. Okay, the physostigmine. Somebody gets bonus points if they can tell me how to spell that and how to pronounce it correctly. But that is the medication that we use in the treatment of MG. When preparing to give a bed bath to a client with Guillain-Barré, we know that they will most likely have which deficit? So complete paralysis, symmetrical weakness, weakness to one side of the body, or sensitivity to touch. And the answer is B. So while we know that it does cause paralysis, it's near or total paralysis, but not complete, right? So we know that it is ascending, but it is not total. So we go with symmetrical weakness that is almost complete paralysis, but we don't consider it complete. Okay. If we have weakness to only one side of the body, then we're going to think more of stroke deficits. Remember the B-FAST scale, and it does not cause sensitivity to touch. It causes decreased sensation. However, they do have those paresthesias, just similar to our diabetic patients have the neuropathy. They are going to have pain even if they are not able to feel the light touch. They are still going to have some pain. Okay, caring for a client with gradual paralysis starting from the toes, moving up the legs. So we understand that their nervous system is being attacked because they are suffering from which? Okay, and then we know that that is the Guillain-Barré, the key being that ascending paralysis moving upwards from the toes to the legs. And we know that there's a disconnect between the nerve and the muscle, and it is progressive, but it does not start peripherally. Okay, the first symptoms with myasthenia gravis then are with the eyes. So if we go back here, A is myasthenia gravis. So we know that it does have a similar mechanism as far as the disconnect, but we would see diplopia, we'd see ptosis. That would be the first symptoms if we were looking at myasthenia gravis. So just understanding again, comparing, contrasting those two different presentation of symptoms. Okay, and they've been diagnosed with Guillain-Barré. What are we going to do? This is select all that apply. So A is assist in range of motion, assist with plasmapheresis, encourage ambulation, provided steroids, or place them in Trendelenburg. And our answers are A, B, and D, knowing that bed rest is encouraged with the head of the bed elevated. Again, we're worried about that airway and respiration. Plasmapheresis we can use with either one, right? But we know it's more beneficial in the acute phase. That's where they have those multiple cycles in the first week or so. We do not want to promote ambulation. We want to promote rest. Yes, they should have some type of steroids or plasmapheresis. And then the optimal position, again, head of the bed up to protect that airway. We do not want them in Trendelenburg. If they're having difficulty breathing, that's only going to make it worse. All right. So that is our quick little review of myasthenia gravis and Guillain-Barré. And hopefully this will help kind of put the pieces together for you going forward.